طيب توكلنا على الله. بسم الله والحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. Welcome you all to our first webinar conducted by Saudi Anesthesia Society in this critical time that the global institutions and medical professionals, they are fighting the COVID-19. Saudi Anesthesia Society also has some roles during this time of period. So just some housekeeping issues here. For all attendees, we have disabled the camera and microphones. So please, if you have any questions, gonna be asked to the panel. Please use your Q&A box that's gonna be appear at the bottom of your broadcast window. If you have any other technical issue, you may need to close your browser and restart again. It depends on your type of your problem. بإذن الله تعالى, at the end of following this webinar, we're gonna the Saudi Anesthesia Society will release a statement which includes recommendation and conclusion of the webinar. So please just follow us in our Twitter account, which is SAS__KSA. COVID-19 safety and challenges of the perioperative care during a pandemic. This is a very hot topic. Globally, everybody is concerned and concerned about this issue. So we're gonna start with discussing different issues in the perioperative period. Just I want to introduce first our experts panel, which is include Dr. Abdullah Hussawi. He's on his way, hopefully. Dr. Abdullah Hussawi, he's the Director General of Saudi Patient Safety Center. Also, he's a hepatobiliary and organ transplant surgeon. Dr. Atul Gaur, he's a consultant anesthetist from in the University Hospital of Leicester in the National Health System, UK. Welcome, Dr. Gaur, and thank you for your contribution. So we have Dr. Abdurrahman Al-Saidi. He's a consultant and head of the infectious disease section in King Abdulaziz Medical City, Riyadh. And it's going to be this webinar is going to be moderated by two of us, myself, Ahmed Abdul Mu'min. I'm currently the president of Saudi Anesthesia Society. Also my colleague, Dr. Mohammed Al-Harbi, he is the vice president of Saudi Anesthesia Society, an assistant professor, consultant anesthetist in King Saud bin Abdulaziz University for Health Science, Riyadh. I will leave the mic for Dr. Mohammed Al-Harbi.
Thank you, Dr. Ahmed. I think this is an excellent initiative by the Saudi Anesthesia Society, and we'd like to welcome all of our guests today to share their expertise in such pandemic which is affecting the whole world. I would like also to thank all our attendees, who are about more than 200 so far, and I think the number is growing very fast. And we'd like to start our webinar today by asking our Dr. Abdurrahman Al-Saidi from infectious disease about the definition of COVID-19 and also highlight the difference between this virus and other viruses. Dr. Abdurrahman? You are muted.
Yeah, assalamu alaikum. Good afternoon, everyone. I hope, thank you very much for inviting me. Okay. Do you see the screen?
Not yet.
Meanwhile, I want to welcome Dr. Abdullah Housawi. Dr. Abdullah, welcome. As I said, Dr. Abdullah, he is the Director General of Saudi Patient Safety Center and the Kingdom. And we are we're so lucky and so glad that he is part of our webinar. Thank you, Dr. Abdullah. Thank you for coming.
حياكم الله جميعا.
Allah يحييك.
Do you see anything in my screen or not yet?
Not yet. You can actually present what you have.
Okay. What about now?
Yes, go ahead, yes.
Okay. Okay, so is it clear right now?
Yes. Clear. Yeah, go ahead, Dr. Abdullah.
Okay, so my objectives are going to be this, whatever is showing in the slide, how to define and confirm COVID infections, maybe a little bit about the nature of the SARS-CoV-2 and why it differs, how it differs than other respiratory tract infections or viruses, influenza particularly, and Middle East. Maybe a little bit about modalities and variabilities of diagnostic tests. And I'll finish by talking briefly about management in moderate and severe infections. The main thing when you talk about how to define COVID infections, we talk about the clinical and epidemiological risk, because most of the time when we deal with these patients, we deal with them as a suspected cases, which is the main thing that we'd like to do, is identification of the cases very early before making a confirmation of diagnosis. And as you can see in the slide, there is the clinical part that will be encountered by the physicians or the front, people in the front line, either in ER or in the clinics or at the borders. And there is then the epidemiological link that will be helpful even in a symptomatic patient, in a mass screening, and then also there are the laboratory and investigations or imaging that can be helpful in some cases, particularly if the screening test is negative. We use it commonly in a hospital setting. So this is the definition of the definition criteria by the WHO, 3 categories: confirmed case, when there is a person with a laboratory confirmation of COVID infections, and the reference standard is usually molecular techniques. And this is regardless of clinical signs and symptoms. And then there is a probable case when there is a suspect case of whom testing of the COVID infection is either inconclusive, indeterminate, or is not accessible. And then the suspected case. And the suspected case is actually, the definition may vary from country to country. It depends on the community spread, how early are they in the spreading of infections. And I choose here the suspected case definition by Ministry of Health or the National CDC. If you can see the slide with me, there are 2 bars, the clinical presentation and very sensitive. And the aim of this to pick almost any case. Number 1 is patient with acute respiratory illness, sudden onset, or at least one of the following fever, measured by history, even if it's not documented, cough, shortness of breath, and also included the incubation period within 14 days prior to the symptom meet any one of the epidemiological criteria. Number 2 is actually any case of hospital-acquired pneumonia or community-acquired pneumonia. And this is the updated case definition on March 29, when there is some spread in the country, and most of the country use these sensitive definitions just to pick up most of the cases. However, that will increase, of course, the cases that will be isolated in hospital, but in order to use early diagnostic, you have to use these measures. In the epidemiological links, history of travel abroad, history of being a resident in an area where there is a COVID infection, either a hospital or a community setting, or a close physical contact with a patient with confirmed case or highly suspected cases. And always there is a questions about the contact, especially from the healthcare providers when they have these, what type of contact should be a risk. And there is a definition by the WHO, World Health Organizations, and the CDC, either the American CDC or the national CDC. And it's defined first by the incubation period, 2 days prior to onset of the symptoms or 14 days after the onset of the symptoms. And the contact will be defined actually by face-to-face contact. And the duration will be defined by 15 minutes minimum. And the distance is going to be 1 meter, minimum 1 to 1.5 meters. There is a variation in this definition. Or direct physical contact with a probable or confirmed case, or direct care of a patient with probable in a healthcare setting without using a proper PPE. And, you know that the PPE will be covered in the second part by Professor Abdullah Hossawi. And definitely, sometimes we use other local risk assessment case by case. Can we differentiate COVID infections from other respiratory infections by clinical history? In fact, it's difficult. And as you can see from these slides that I took it from, it's actually modified. Doesn't mean to be very scientific for the public. It was made to differentiate. In the middle of the slide, you can see the symptom. Here is the coronavirus, cold and flu, fever, fatigue, cough, sneezing. And if you look particularly coronavirus and compare it to flu, there is not much of a difference. Fever, common in either one, fatigue, cough, sneezing, and the usual influenza-like symptoms. Here I just put using multiple references to see what will be the percentage. Fever.
Dr. Abdulrahman, yes. How reliable is the test now for detecting COVID-19?
Okay, so as I said, the clinical will be difficult to differentiate. The test, which is the molecular method that are used nowadays in most of the national centers and in our local centers, actually validated, approved by the CDC, is very sensitive and specific test. However, there are a number of factors that can affect the sensitivity. Maybe we'll talk about it in the second slide. But it's the real-time PCR is the reference standard. Antibodies can be used nowadays. It's taken initially, the sensitivity was poor. However, we are seeing more and better antibodies. Culture, of course, in the research lab and the clinical sites. Maybe I'll talk about in the second slide about the sensitivity and yeah.
I think we will move to Dr. Abdullah Hossawi now. Thanks, Dr. Abdulrahman, for a nice introduction for this disease. I think with having the General Director for the Saudi Patient Safety Center, Dr. Hossawi will tell us about the safety for healthcare worker. I know this is very hot in the media everywhere, people working and you see in the media, nurses, physicians. So we'd like to hear from you, Dr. Abdullah, about this safety measures.
Assalamu alaikum wa rahmatullah jami'an. I hope that you can basically hear me well and see me. Trying to share my my screen, but basically let me just do one thing because I have my presentation up, but I just want to share my screen. I'm clicking on sharing the screen, and somehow it's not coming up. Let's see, if I go to Files, Advanced. That's interesting. Anyway, I'm not sure. I'm not sure what happened. I had it up, but first of all, let me just what I'm going to talk about is very specific. So to start with, I think everyone that works in healthcare should feel proud of all the the efforts, people going the extra miles, putting their lives and their livelihood at risk to help patients. I think everyone that works in healthcare deserves basically recognition and acknowledgement of this very important work that hopefully once this is said and done, the health workforce will be identified and recognized more. What I'm going to talk about is basically the magnitude of harm in general on a regular time, and then specifically during pandemics. And then I'm going to talk about some aspects of patient safety for both COVID-19 and non-COVID-19 patients. And I'm going to end up with a very important topic, which is the workforce safety. So we think, as you probably, most of you know, that we put patient safety in the G20 agenda during this year's of the Saudi presidency. And the point was that almost around 5 million people lose their lives on an annual basis from preventable harm. And we know that 70 to 80% of the harm that takes place is preventable. Now, this is on a regular, time. So think about what would happen when you are in a pandemic, whether COVID-19 in this time or any other major pandemics. So there are very kind of specific aspects of safety in COVID-19 patients, and I had slides that show COVID-19 patients in the operating room, in the diagnostic imaging department, in the ICU, and if you could just look at the attire of the people are having, and how very kind of difficult it is to deal with those patients, you get a sense of many of the challenges that COVID-19 patients are dealing with. These are maybe the ones on the sick part of the spectrum, but even patients that are not that sick, because of the responsiveness of the healthcare system and the fear of many of the health workforce to deal with them, that can put them in some challenges. On the other hand, and I think this is, if there is one take-home message from my discussion today, is also the safety of non-COVID-19 patients. Many people talk about the fact that all the diseases that we were very busy treating and we will continue to treat did not go away. Cancer did not take a vacation. Heart disease did not take a vacation. All the other illnesses that we treat did not take a vacation. And if you have study many countries, you would see that there is a concern about some very important diseases and their treatment. Cancer treatment. Many patients with cancer are having difficulties accessing healthcare, and there are two reasons for that. One is many patients are worried about going to healthcare facilities and potentially being exposed to COVID-19. But on the other hand, also because hospitals are trying to be prepared to deal with COVID-19, those urgent cases are kind of being delayed, and this is why, and I really want to thank the Saudi Association for Anesthesia as one of the early societies that have collaborated with us on our intervention to prioritize cases. So the Saudi Patient Safety Center introduced a prioritization framework, which is very simple framework. You have red, which is emergency cases that have to be dealt with within 24 hours, orange, which is cases urgent and semi-urgent that need to be dealt within a day to 30 days, and yellow, which are elective cases that could wait up to more than 30 days. And then we reached out to the medical societies and asked them, based on their expertise, how can they help us, put those cases in perspective. We've received so far from 17 societies, and I think the numbers keep going up, even from other societies like dental, like ENT, etc. So I ask everyone to kind of look up our website, and it's very simple. You can even just use a QR code to get into that area. Now, the last point that I want to finish with is the workforce safety. And I think this is where we, from the very beginning in the Saudi Patient Safety Center, our vision statement is safer healthcare for all. And we made it clear that patient safety and health workforce safety are interdependent. So it's not zero-sum game. It's not like if you work on patient safety that you're gonna overlook the staff safety, or if you work on the staff safety, you're gonna basically overlook patient safety, because both are at the sharp edge, at the clinical setting. And I believe we see that there are many needs to make sure that there's a standardized approach to dealing with patients, because a COVID-19 patient, as the brilliant presentation before me illustrated, is not going to come in their forehead saying, I'm a COVID-19 patient. So anyone in the healthcare system, even like housekeeping, could be exposed to diseases. So how can we look at some high-risk areas and make sure that there's a standardized approach that everyone uses? And how can we also make sure that, when it comes to the peri-operative situation, which my colleagues are going to talk about, how can we make sure that while we're providing this very needed care to patients, that we also make sure that the staff are safe, so providing the PPEs, but also having, kind of mental and psychological support to the staff, but having standardized approach to deal with it. The very last point I also wanted to mention is the business continuity plans. When we've reached out to some of the hospitals, it was clear that there was no business continuity plan, which in a way, when you are dealing with a pandemic or with an emergency, you also have to, on one hand, deal with the emergency, deal with the pandemic, but on the other hand, continue to operate and provide your services and make sure that on a daily basis that you are prepared. And part of the business continuity plan is to make sure that you also continue to treat the important diseases. So I ask every hospital in the country to make sure that they have an updated business continuity plans. We also introduced just some guidelines about business continuity plans on our website that I think can be helpful for hospitals, because now when you talk about patient safety, it's not just the errors of commission that we worry about, but also many of the errors of omission because of difficulties of access, either from a patient perspective or from a healthcare provider. So thank you very much for giving me the opportunity, and I apologize for not being able to put the slides, but I hope the message is clear, and I'm ready to answer any questions during the Q&A.
Thank you, Dr. Billah, and I really appreciate your input. But I have a question. Do usually the Saudi Patient Safety Center, do usually they have some authority monitoring on the stock of the PPEs, and how much hospital usually they have enough stock of PPEs? Do you have such information?
No, we don't. Well, that's not part of the mandate of the Saudi Patient Safety Center, and I think this pandemic illustrated the need to make sure that we have also kind of a standardized infection prevention control aspect to it, because on one, this has different aspects. It has an infection prevention control to it, aspect to it, but then there's also the surge capacity and the supply chain component. what I know is from early in January, when the signs of this pandemic were kind of at the early stages, there were very important, decisions that were made by the government that all the factories kind of working on PPEs to kind of stop producing anything to the outside until we make sure that we have enough capacity. Because on one end you have major suppliers like China and India also being impacted, and the whole supply chain is affected. So there was a real need, and I think you see that in many countries trying to make sure that their national stockpile is enough before kind of going and losing that, because many of the health workforce are paying the price for that.
Great, thank you, Dr. Thank you, Dr. Abdullah, and. So actually, we may say that our SAS message after this valuable speech from Dr. Abdullah is your personal protection is a priority for us as healthcare professional, and so PPE should be available to all providers to ensure droplet contact isolation precautions can be achieved. Also, careful attention is required to avoid self-contamination. Dr. Abdullah, do you want to comment on our message to our colleagues, healthcare workers? Dr. Abdullah?
Yes, sorry. Absolutely. So I think the PPE, the message that the PPE should be available for all providers to ensure droplet and contact isolation precautions can be achieved is a very important message. I think again at the level of a hospital, this is where you need to have kind of practical plans on how these PPEs are distributed. You need to also to have plans on how to not to kind of reach levels where you're struggling and you don't have those very important personal protective equipment. I think it's also very helpful to get, and maybe this is something that that your society can do, is to get just some input from professionals, about whether or not they have witnessed any difficulty, getting some feedback on how you can translate, those national level strategies into some practical, policies and procedures at the bedside, because I think what matters is at the bedside. One other important thing, and I think probably many people have thought about it, is not just the availability of the PPE, but do healthcare professionals actually know how to what's the proper way to put the PPEs on, and what the proper way is to take them off. Maybe people that work in the operating room, like surgeons, anesthesiologists, etc., people that handle the PPEs on a regular basis are aware of how to deal with those. I think it's important also, in addition to that, to really highlight having some simple clips and videos on what is the proper way to put a PPE on, what's the proper way to take it off. I think we in the peri-operative field are very comfortable doing that. but we have, the majority of healthcare professionals not being familiar to deal with PPEs on a regular basis. And I think that's an important message to highlight.
Great. I agree with you totally. And inshallah, maybe before the end of our webinar, we're going to present such similar small video that we get the permission to publish it. Before going to the next step, I want to show you that please visit our Saudi General Anesthesia website. We have published as a society for policies and procedures for patient who is known to have COVID or suspect. The patient going for thoracic surgery, patient going for OB surgery, patient going for ophthalmic, and also the airway management of a patient who is COVID or confirmed. So please, SaudiGA.org, please go ahead and have a look to our articles that was published ahead just maybe last week.
Thank you very much. That's amazing.
Thank you, Dr. Abdullah. So actually now we're going to Dr. Atul Gaur. Dr. Atul, that I want to again reintroduce him, that people who did not follow, he's anesthesia consultant from Leicester University, Leicester, UK, and he will start to talk to us about the ideal OR setup and the aerosol genetic procedures and cross-infection, what to do, and also he will have a hint about airway management for suspected or confirmed COVID-19. And before that, before that also Dr. Atul, he will have he will give us some continuation of what Dr. Abdullah said about whether to continue a routine surgical operation during pandemic or not. So go ahead, Dr. Gaur, and good luck.
Thank you, Professor President, and thank you, Director General Sahab. You rightly said that you congratulated the society for taking up this issue. Obviously, we are trained to be more safe, and then I think probably we are one of the safest specialty in medicine. So thank you very much for appreciating that. Regarding what kind of operations we should carry on, whether routine surgical operations or not, I would like to share my screen, and then we'll go through a few slides. I hope you will be able to see them very soon. Yeah, so can you see my screen now? Please, yes, I think so. All right, so let me go. So I will be covering routine surgical operations during COVID-19 pandemic, and then a special case. So I will generally cover routine surgery and cancer and vascular surgeries. Most of my talk is based on the evidence and our guiding healthcare agencies like Royal College of Surgeons and Academy of Medical Royal Colleges. During such difficult times, we should be trained to work beyond the scope of practice. So it all depends upon the workload. So if we are well into the too much of COVID patients, then probably we need to practice beyond our competencies, but then we should be guided by someone who is trained in the particular specialty. So it all depends upon local need, and appropriate training should be provided to the team who are working. In England, we have invited our retired medics as well and trainees, and then there is a provision in our Medical Act 1983 to provide them temporary registration. So we are using those provisions to improve our workforce. Basically, routine surgery needs because of COVID-19, it needs service adjustment. And we have certain recommendations, but then they should be adaptable. They should not be very rigidly followed. It all depends upon the surgical services available to us, whether we can provide extended role or not, our professionals. And then we should also think about caring for patient at the end of life, because that is very important. Many times you're not able to provide them support because we don't see that outcome is very bright. At the same time, we should take proper care for protecting our workforce. As Director General Saab said, that healthcare workers are very important. I think probably there are 600,000 healthcare workers in Saudi Arabia, about 13 or 15 million in America, and about 1.5 million in India. So there's a very large workforce which is important to be protected to tackle this situation. Regarding surgeries, we go through the NCEPOD classifications. We divide them into immediate, life, limb, or organ-saving interventions, urgent, acute onset or clinical deterioration, and expedited ones, which requires early treatment, and elective ones. So elective ones are no-no. We stop doing all routine elective operations after till 15th of April or so. But then situation is evolving, and then our goalpost is moving always, depending upon the situation. We should review a person who is trained, who is very senior consultant, and a team should review all scheduled elective procedures and either minimize them or postpone them or cancel them, depending on the merit of the case. So there should be a triage of non-emergency surgery. And then we should utilize our clinical network. It is not necessary to do all operation in one particular hospital. So we should have clean sites marked, and then we should work there. Say, for example, clean trauma goes to a particular hospital and other operations goes to another hospital, so that we are utilizing our services properly. We should make rota properly so that every staff is getting enough rest, and then we are able to provide expertise to a particular surgery. And for routine consultations, virtual outpatient clinics should be set up. Regarding progressive diseases like cancer and vascular surgery, we should consider what is the risk of delay. Whether if we postpone them, can they arrive as an emergency? And then whether we have got resources then to tackle those emergencies. So we should keep about these things in our mind. We should have a logistical review of our capacity for performing the procedures, and should assess the real risk of proceeding versus risk of delay of any operation. As mentioned earlier, we should avoid blanket policies regarding triage. They should be done under consultation of a very senior team, and then we should keep working depending on the situation. In cancer surgeries as well, there are many vulnerable patients. There are few conditions which are already known, like active chemotherapy, radical radiotherapy for lung cancers, cancers of blood, and so on. Age is also a very important factor. When age is associated with certain comorbidities, then we need to think about the outcome, whether we are doing good or we are engaging our services where we can provide services to a more number of patients. So we need to think about that. We need to, and ethically we should be covered about that. It should be done through a consultation between a team of experts. Then we can divide the cancer surgery priorities as well into level 1A, which are emergency operations, which are needed within 24 hours, level 1B, urgent operations needed within 72 hours, level 2 and level 3. So elective surgery is level 3, which can be delayed for 10 to 12 weeks, even when they have a cancer. Okay, so we need to think about all these things. So that is about the surgical procedures, President Sir. You want me to carry on, or you want me to stop sharing?
No, actually, go ahead, Dr. Gore, because we're gonna have a Q&A at the end of the session.
Okay, all right. So, okay, that's good. So about then, let us come to the logistics then, about cancer surgery logistics, and then caring for the patient at the end of life is also very important. Decisions to withhold a surgical intervention is very, very difficult and emotional and have psychological impact. But then this should be done under the guidance of very senior people. Patients and their carers should be involved into the decisions. We should try to make remote contact, because it is not possible always to talk to them one-to-one, face-to-face. But then we should try to make attempt to talk to their family, multidisciplinary team, and palliative care team as well, because that is very important. And then we should think about advanced care plans, and we should, even in these difficult times, we should always give a patient a respect and offer them a choice. So that is about the elective surgeries situations in COVID pandemics. As far as pre-assessment is concerned, when patient comes to us, we should go through as usual, take proper history. If it is an elective procedure, we can ask them to isolate 7 days in advance. We can offer them few tests, probably 2 days before their operation, and then we should go for chest X-ray. If patient for any reason goes for a CT examination, then it is a very good idea to have chest CT as well. Patients should be assessed by senior clinician anesthetist so that they can assess the difficulties. They can rule them out or prepare accordingly. So that's how we manage with the surgical procedures, routine or cancer or progressive disease procedures. Is that okay?
So we're gonna we'll go to the next section, Doctor, about talking about the cross-infection, the fear of cross-infection of aerosol genetic procedures.
Okay.
Please. Yes,
Yeah.
please go ahead.
Okay, so I will talk about then the aerosols and how they can affect the cross-infections. This is a very interesting topic, and it needs a lot of thinking. We work in indoor work environment. In outdoor environment, we say keep social distancing, and normally 2 meters of distance dilute the aerosols or infectious load, and that is safe enough. But then when we work in indoor work environment, we already know that there is increased risk of respiratory diseases, especially with the routes of transmission like inhalation of infectious bioaerosols and exposure to that. So as mentioned earlier, approximately 3 million healthcare workers in England, which is about 11% of total workforce, and 600,000 in Saudi Arabia. So we need to think about them because they work in these indoor premises. It is quite possible that if we take proper measures, we can have a potential effect on their health and healthcare cost. And therefore, we should think about effective preventive strategies like air recirculation between regions of building. Now, what is the aerosol? It's a very common question. So aerosols are suspension of particles in a gas, usually air. Air can be both solid and liquid particles with dimensions from a few nanometers to around 100 micrometers. So we can say small droplets and large droplets. And then size can be determined. Less than 5 microns are small droplets or aerosols, and more than 5 microns are large droplets. Now, mask-like provisions, they stop large droplets, but then they don't have very, very, very good effect onto these small droplets because they come out as the aerosols. We know that COVID-19.
Excuse me, do you have any slides you want to present in this?
Oh, is it not going? Oh, sorry.
Yeah, that's why.
Oh, sorry.
No,
yes,
no,
thanks for reminding. Thank you for reminding. Yes, I want to share slides.
Yes,
Okay.
yes, please go ahead.
Yeah. Thank you very much for reminding. Sorry, guys. So I was talking about the aerosols that we work into indoor work environment. You have already heard me about that. Okay. And then I was discussing about what is aerosol, and then small droplets and large droplets based on the various sizes. Say, for example, we can say less than 5 micron or so. And then I was then talking about the COVID virus, which is round or elliptic, and then often pleomorphic form, and then its size varies from 60 to 140 microns. And then it can remain viable in aerosols for hours, and that's why it's very important. And many infected individuals who are not asymptomatic, they can also transmit the infection. So that is the danger. And then there are already publications about that. We perform in hospital various aerosol generating procedures. Basically, they can be divided into two: procedures that mechanically create and disperse aerosols, and procedures that induce the patient to produce aerosols. Say, for example, if you're doing something which is inducing coughing, like bronchoscopy or catheter suction, then that can also produce aerosol. Or if we are doing certain procedures like we are ventilating them, CPAP or high flow air, or we are intubating or extubating, that also generate aerosols. So we need to think about it. The aerosol propagation, or the cloud of aerosol which comes out, it takes something like the shape which is denoted by a blue line in the picture. You can see that, a visible plume. So if we talk about then a propagation of in terms of visible propagation and velocity of nasal breathing, mouth breathing, sneezing and coughing, then you find that sneezing and coughing, they both have similar spread of the droplets, while mouth breathing and nasal breathing, their distance is reduced dramatically, okay? So we need to think about that. But then yes, that means that when we breathe in, breathe out, then also aerosols can get generated because they are very micro particles, nanoparticles. Here in this shadowgraph, you can see that how this coughing procedure that produces the aerosols. And to compare, first you will see unmasked cough. I hope you can see those things on the screen, okay? And then cough into a fist. When we make a fist in front of our mouth, then what happens to the cough? You can see that it is going down there. Or coughing into a cupped hand, okay? So this shadowgraph shows us various ways the aerosols can spread, and coughing into a tissue is a very effective way. One should have very good, many layers of tissues and then cough in case we are in outdoor situations. Or coughing into a cough catcher device also helps, okay? All right, so these are the various ways that the aerosols can spread. Also, then there is one very good publication in New England Journal of Medicine, which shows that without mask, how these particles, droplets looks like. You can see that green droplets in the screen on left-hand side. On right-hand side, you can see with mask. So number of big droplets reduces drastically when we use mask. So we should think about it. Now, because we are talking about aerosol, then we should talk about its spread, because we are working in indoor environment. So if we talk about airflow in positive pressure operation theater, you can see an operation theater layout onto the screen, onto the left side, okay? So, and then if I add to that, now this is without any flow. And this middle picture, you can see orangish structure, which is more contaminated. Right beneath that, you can see operation table. It is a depiction only. And on both sides, you can see surgeons or anesthetists. And by side of them, you can see other articles like suction machine or other things. And new things, and then the blue things, you can see as a clear air. Okay, so this shows the a normal pattern of contaminants if there is no flow. And here you can see a positive pressure flow. So positive pressure flow comes from the top. And then on right side of the bottom picture, you can see more orangish, greenish structure and red structure. So the duct outlet is closed on that side, while onto the left side of the screen, duct outlet or outlets are open and that contaminants goes out. Now, this is very interesting finding. Another slide, I will talk about that. Another slide depicts the airflow in buildings in Hong Kong during SARS 2004. And then they could find out that how come infection spread from someone who went to floor 7 and then his toilet having some problem, and then the extractor fan probably was not working, and then in Amoy Gardens, and then there was a spread of infection. So we can take some idea from these settings or studies regarding our own indoor environment in hospital. Here you can see the distribution of virus-laden aerosols in ICU or in operation theater. Near the patient's bed, you can see that is side 2. Side 1 is near the ducts which are going out, and side 3, you can say, is the office of the doctors. And here you can see in side 1, near the air outlet from the operation theaters or doors or scrub area, the aerosol concentration is about 37.5%, while at the near the patient, it is about 44.4%, and on side 3, which means that near the offices where we sit or relax outside, it is about 12.5%. So which means that this aerosol spreads inside the building. Okay, and then we should be aware of these things. So therefore, then comes that how we can manage airborne contagious patients or diseases. One Chinese publication, why it is important, one Chinese publication says about 41% cross-infection in radiology suite. Now in radiology suites, bear in mind, in radiology suites, they don't do aerosol generating procedure. Even there, they found, even when they were protected properly in China, because they had very good PPE practice there, they found that 41% cross-infection chances were there, 29% among healthcare staff, and about 12% or so amongst other patients who were not non-COVID. So therefore, we should have negative pressure theaters to help, because that's what we know. And then negative pressure theaters are where there's a difference in pressure between the adjacent areas like corridors and negative pressure room, which causes movement of air from the area of high pressure to those at lower pressure. And normally these negative pressure rooms work at 12 air changes per hour, which is not very effective. 12 air changes per hour, if we have 50 air changes per hour, then probably reaching 99.9% efficiency, we have to wait for 10 minutes. And then you can see the 12 air changes not good enough to remove the contaminants. The slow air rate change increases the time taken in efficiently removing the infectious load. So therefore, and also before this air gets out, these aerosols, they contaminate the room itself. So therefore, you should try to have some preventive measures. And then we tried. We tried in UK and we tried in India as well. So what we have done is that we have come out with infection control assist device. Basically, it's based on a concept to reduce the size of this negative pressure room, because negative pressure rooms are very big. So instead of allowing this aerosol to contaminate the room, we limited that area like a hood, okay? And then to contain the aerosols and to evacuate it outside. To evacuate it outside into the atmosphere, we use the central suction system. So then 2 suction tubes goes inside the device, and then they remove the aerosols directly out into the atmosphere. And then these one suction tube draws up about 40 liters of air. That means if we look at the capacity of the device, then we are removing about 60 to 80 liters of air per minute. So that means that we are causing air change every 30 seconds, which means in 1 hour, we are changing 120 times air, and that improves the efficiency. So if we go by the studies done in negative pressure rooms, limiting the area where aerosol is generating by a transparent medical grade device, we can get rid of aerosol contamination into the adjacent theaters. And then this study shows that the efficiency is improving by the changes of the air. You can see when there are 50 air changes, then 90% efficiency of a negative pressure room is achieved in 3 minutes, 99% in 6 minutes, and 99.9% in 8 minutes. And if you look by these, the device is allowing 120 times air changes inside the place where aerosols are generating, then the efficiency 9% will be achieved faster, and also it will stop contaminating the negative rooms. The device which is in the UK, it looks like something like this on both ends, head and on the left hand side you can see a prototype, first prototype, which we made using a bucket, which was covered on both sides with a clear. So this is a purpose-built device. This is not like a device with incubation boxes or other incubations where you have holes to insert your hand. No, anesthetist's hands should not be restricted because we perform a critical care procedures. If we have restricted movements, we cannot perform the procedures like laryngoscopy, intubation, suction, bougie placements, etc., with ease. So therefore, both should be open. The suction power should be enough so that air changes are fast. The air is getting drawn from the surrounding theater atmosphere, and both ends are covered by plastic, clear plastics. So, and then this is of this shape in India, which we are developing. So that is what we are trying to do. The USP is that we have protected the IP by applying for the intellectual property. The University Hospitals of Leicester, UK is supporting it. Indian Institute of Public Health in India is supporting it. And then we have followed the medical physics guidelines to make it safe. The Medicines and Healthcare Products Regulatory Agency in UK said that there's no need for going for the CE marking for a medical device regarding this device, because this is not medical device, because this is not implant, this is not a treatment. Also, it doesn't come into the category of PPE because it is not protecting. The person who is getting protected is not putting it on himself. It is loosely arranged onto the patient. So our life became very easy. So then it can be used as a general medical product. So we are just into the production phase, and we have got many USPs about that, and that's about it. President Saab, is that okay?
Thank you.
Thank you very much.
No, thank you, Dr. Atul. So if now patient is ready to go to our, and he is ready for anesthesia. So can we continue the journey, Dr. Atul, to that for his airway management, please?
Okay, thank you very much. I'll share my screen again. Thank you.
Sure.
So airway management is very, very important, crucial for us anesthetists and intensivists, and then the people who are working in accidents and emergencies. And therefore, we should follow a pattern. We should have a checklist. AAGBI, Association of Anesthetists of Great Britain and Ireland, have advised a chart. And then every one of us, depending on the local policies and local protocols, and with the help of you senior guys, they should make a checklist so that we are not missing out on anything. So there are a few things like PPE. We should wash our hands. Then buddy should be checking us. We should put on PPE, and list goes on. It is very, very exhaustive list. But then this is very, very important, and all of us, we should go through these, and we should practice this practice, because we have never practiced these things in a particular order. So therefore, we should practice to get used to all these things. The airway management differs whether we are putting in, whether we are securing the airway in operation theater or in ICU setup. The pre-assessment and plan should always be chalked out by a very senior person in the team, because then they can appreciate the difficulties, because there may be time then where that very junior person is working with us, because many healthcare workers are either not available because of the rota, or they are not able to work because they got cross-infection. So the patient should be assessed by a senior person. Then laryngoscopy procedures, I'm just talking through in general first. They should be used as per the local protocol, whatever you are comfortable with. If you have got video laryngoscopes, then that is better, because then intubation is much easy. The induction agents or muscle relaxants used during the COVID-19 situation, whether the patient is COVID positive or not, we should consider all patients as COVID positive. And then induction agents can be used as per the choice of your local place. Like you may like to use reduced doses of propofol or ketamine or any other induction agents to induce an anesthetics. The muscle relaxant, we try to avoid succinylcholine, because there is evidence that that can promote the release of aerosols. So therefore, we use high doses of rocuronium, about 5 to 6 milligram per kg body weight. The ventilation, we should make sure that we have got viral filters, viral HEPA filters attached onto the both limbs of the circuit. And then we should decide about the mode of ventilation. When patient is breathing spontaneously, when we are assisting, we should try to have as low flow from the machine as possible, so that we are trying to generate as low aerosols as possible. And then after that, we can go on to the ventilation. When we are on ventilation, then end-tidal carbon dioxide is the very good way of monitoring the ventilation rather than using stethoscopes. Use of stethoscopes should not be allowed, or we should not use stethoscope, because a stethoscope can act as a very big carrier, and then we go very close to the patient. We have to bend down to listen to that. And then we should know a bit about prone nursing as well if we are thinking about ITU. So these things are important about the airway management. As I mentioned, practice, practice, practice. In England, what we have is normally we have got a 2-room, but there can be 3 rooms as well. So people can prepare medicines from outside the operation theater reception or anesthetic room. They can prepare the medicines or drugs and hand over to the person, like this girl who is looking into the scrubs, and then she can then take knock the door of the operation room or the room where patient is being intubated, so that the inside team can pick up the things. And then you can see the inside team in the bottom picture. And then everyone define their roles. We should use checklists very often, especially into the beginning or every day. And then you can see that the person who is intubating is standing onto the head end. A person who is helping is standing next to her. And then a person who is assisting as well on the other side, right side, and someone who is a floater onto the foot end of the table. So number of personnel can vary as per the hospital setups, as per the resources available. We should always think about backup, because in case something happens, then the backup should be available quickly, because backup, when they arrive, they will be putting on PPEs as well, what we call donning and docking. So someone else will be talking about that. We should have a team briefing before that. And we can divide whole procedure into various phases, and then phase, preparation phase, like post-donning preparation phase, like intubation phase. So that's how we can think about the airway management in operation theaters. Is that okay, sir? Is that okay, Ahmed Sahab?
For your excellent presentation and your experience from in Leicester University Hospital, actually. And we need to exchange because this is a new disease, actually. It's a new disease, and we need to exchange our experiences with each other in order to reach to the utmost proper management. Hopefully, I want to before I'm going to next step. I want to we have here. Just this message, SAS message, and if Dr. Atul you want to comment on it after I finish it. This message is a summary of some of our recommendations from our paper that we published in the Journal of Anesthesia and Airway Management. So the message that we may get out of what we talked about before is patients should not be brought to halting or post-anesthesia care unit areas. They should go immediately from to the ORs. Patients should be managed in designated OR for COVID, with signs posted on doors to minimize self-exposure, staff exposure. Should be recovered in OR or transferred to ICU into a negative pressure room. Also, we should ensure a high quality heat and moisture exchange filter to be available in order to remove at least 99.97 of the airborne particles. And this should be placed in between the ET tube and the reservoir bag during transfer to avoid contaminating the atmosphere. So, Dr. Agor, do you have any comment about this message before going to the next one?
No, Ahmed Sahab, you are absolutely spot on, and then all these things should be followed very religiously. Yes, thank you.
Thank you. Yes, Dr.
Can I just ask a question? So
yes.
The operating room is a positive pressure room, while so a patient with COVID-19, at least someone who's confirmed COVID-19, is ideally should be in a negative pressure room. So are there any, and the question to you all as anesthesiologists, are there any specific conversations that one should have with the engineers in the hospital about that designated OR? Because again, it will continue to be a positive pressure room, and how do you handle that? Are we talking about a number of HEPA filters? Are we talking about certain aspects to be added just to get the OR? Thank you.
Yeah, thank you, Director General Saab. Your question is very, very important. And then converting positive pressure rooms into negative pressure rooms is not easy. It is huge cost, billions of pounds. And not only that, it will take time. And then when we tried here, it was very good. And that's why somehow, luckily, I got this idea of reducing the size of the negative pressure area to make this more efficiently done. So yes, ideally there should be negative pressure room, but then we should keep in our mind that even negative pressure rooms, the air change is very slow, 12 per hour. And then if we go by the studies in past, then probably that will take about 30 minutes or so, approximately, time to remove the contaminants from the room. Now, if you look, I can't say for sure. But then when I was auditing the death of healthcare workers in world, especially in Italy, what I have noticed is that out of 109 doctors who died, only 1 or 2 anesthetists died. And then I thought that anesthetists, they perform aerosol generating procedure. So if COVID is killing the healthcare workers, then anesthetists should have a higher mortality rate. Then I thought that anesthetists are saved because they are having proper PPE. And that's how I started thinking about indoor pollution. So it is quite possible that healthcare workers, those who are in normal area, where they are not performing AGP, they are very complacent. That is a possibility. That's a hypothesis. And therefore, they get exposed to more infectious load. And that's why there's more chances of cross-infection into the healthcare workers, those who are not well protected. So that can be one explanation of this.
That's a very interesting point, and I think, you know, it goes back to the point that I mentioned about the fact that the people that work in the peri-operative field are very comfortable using PPEs. I think if this hypothesis stands with many countries, I think this is a very important finding, that the implication is we need to train people that are not comfortable with PPEs to do that. I think that is a very important point. I wasn't aware that there are only very, very few anesthesiologists that died in Italy.
Yeah, that's why this is very important. That is my baby, so I would definitely love it. But then, yes, I think probably this invention is very, very important and timely. And then I think probably we should take care of other healthcare workers who are not doing directly aerosol generating procedures. And then we should think about that if this hypothesis is correct. When I was looking at the data by Medscape, which is an online thing where people go by their choice and then register the colleagues who died. When I was looking at that, I was shocked to see about 110 people or so out of 379 were physicians, either general practitioners or physicians. And then about 6 or 7 were pathologists, hematologists. It is surprising. They work far, far away from the active area. And about 6 were radiologists. So the number of doctors who are not directly involved is quite significant.
Thank you very much, Dr. Abdullah. I think a very crucial. And thank you, Dr. Gore, for your comprehensive talk. As we said, please write your questions, and Dr. Harbi, he will try to get some of the questions and redirect it to our speakers at the end of the presentation. Now we reached to the section of donning and doffing during COVID, and as Dr. Abdullah, he mentioned that, and Dr. Gore also mentioned many times, that this is a very important section. And in order just to protect ourselves, and donning, which is putting in the BBEs, doffing, which is taking out the BBEs, is very important. And we thought in our presentation would be the best thing is to have a practical presentation rather than to have slides. So we had a video that was published, was done in Sunnybrook Hospital in Toronto, Canada, and we had the permission by Laura Tyler to present it here. So, oh my God, yeah.
For novel pathogens such as novel coronavirus, MERS-CoV, or avian influenza, the recommended additional precautions are airborne, droplet, and contact precautions. These require you to wear the following personal protective equipment: gown, fit-tested, seal-checked N95 respirator, face shield, and gloves. When donning PPE, perform hand hygiene for 15 seconds. Apply 1 to 2 pumps of alcohol-based hand rub to the palms of dry hands. Rub hands together, rubbing palm to palm, in between and around the fingers, on the back of the hands, as well as the fingertips and nail beds. Continue rubbing until hands are completely dry. Hand hygiene using alcohol-based hand rub is the preferred method. Use soap and water only when hands are visibly soiled. Tie back long hair if applicable. Do not bring unnecessary equipment in the room. Inspect your equipment for any damage prior to donning each piece. Clean shaven? Don your gown. Tie around the neck and around the waist. Secure gown using a bow that can easily be untied. Ensure all clothing is covered by gown. Lift your chin and place your fit-tested N95 respirator over your nose and mouth. Stretch the bottom strap over your head and place it on the back of your neck. Ensure strap is on bare skin only, no loose hairs. Place the top strap on the crown of your head. Ensure that the straps are not overlapping or crossed. Check if mask is properly formed to face. Ensure no fold by running fingers along the edges of the mask. Mold the metal nose strip to conform to the shape of your nose. Do this by placing both your middle fingers at the bridge of your nose and use your index finger to press along the edge of mask along for the sides of your nose into the cheeks, creating a good seal. Repeat pressing index fingers with pressure especially alongside of the nose. Perform a seal check by placing your hands at the side of your face at eyebrow level without touching the mask. Exhale quickly once to check if air escapes the mask and hits the palms of hands. If you feel leakage, readjust the fit of your N95 respirator and perform another seal check. Don your face shield by placing the strap at the back of your head. Ensure that the top of the face shield is resting in the middle of your forehead. Put on your gloves. Ensure that gloves are placed over the cuff of the gown so that the skin of your wrist is not exposed. Perform a final personal protective equipment check prior to going into the room. Alternatively, have a colleague perform the final check. After entering the patient's room, keep hands away from your face. Only open one door at a time to maintain negative pressure in the room. The doffing process poses the highest risk of transmission to healthcare workers. Make sure to take your time removing your personal protective equipment. A guide will be posted in the anteroom outlining the steps of PPE removal for staff. Please refer to this guide when doffing your PPE. Step into the anteroom and ensure the door is closed behind you. Remove gloves using the glove-to-glove and skin-to-skin technique. Place in the garbage. You may perform hand hygiene at this time if there is any concern your hands became contaminated during glove removal. Next, untie the gown around your waist and at the neck. Grab the straps from the back of the neck and slowly pull the gown forward and peel it away from you, touching only the inside of the gown. Be careful not to let the gown touch your clothes. Roll the gown into a ball, place the reusable gown in the laundry hamper. If you are using a disposable gown, dispose of it in the garbage. Perform hand hygiene for 15 seconds. Remove the face shield by grabbing the strap at the back of your head. Slowly remove it down and away from your face using the sniff position. Bend forward, eyes forward, chin out. Dispose of the face shield into the garbage. Remove your N95 mask without touching the exterior part of the mask, again using the sniff position. Remove one strap at a time, starting with the bottom strap first and removing the top strap last. Remove the straps by grasping them from the back of your head. Dispose of the N95 respirator in the garbage. Perform hand hygiene. Rooms with anterooms are the preferred accommodation for patients under airborne droplet and contact precautions. If there is no anteroom, remove all PPE inside the patient room at the doorway, with the exception of the N95 respirator, which must be removed in the hallway.
Great. Dr. Abdullah, do you have any comment, Dr. Abdullah, about it?
Yes, let me wear my surgeon's hat here. I think you know, we're dealing with many patients. You know, some of them are known to have hepatitis C, hepatitis B, etc. What we've found as surgeons, and again, you can ask as many surgeons as possible, that when we're done with procedures, we usually, you know, we take out the gown while the gloves are still on the gown. So when the gown comes out, it comes out with the gloves. And this way, because I was a bit concerned just watching the gloves coming off. I think this is a moment where, if you're not careful, you could actually have some whatever you know, patient fluid on your body. But if you have the glove on top of the sleeve all the time, and then when you take out the gown with the gloves, then that is a moment that you're more comfortable. I think, again, being aware, because this is a very good clip, but I think just being aware, making sure that based on the local setting, because different settings have different, you know, situations, I think, and training and simulation, I think, is the key. Again, I'm basically, I think this is an area that maybe people that work in the peri-operative area could also help with training for other healthcare professionals.
Thank you, Dr. Alhamdulillah. I think we have many questions. Also, we have some, before we close our agenda today, we have some ethical issues caring for those patients, especially if the patient, this question for Dr. Abdullah and Dr. Tolgor also. Patient, as you know, the surge, sometimes you have maybe 500 patients and you have a limited resources. So any advice prioritizing such patient, the younger versus the older, or vice versa? So this is one of the ethical issues, a dilemma that we'd like to highlight. Dr. Abdullah?
So I think, we've heard about some of the stories in some of the hospitals in countries like Italy where there are these challenges of prioritizing patients. But I think at the end of the day, having a robust risk management approach on how to deal with patients would help you with that. I hope, and even when you look into some details, even many places in Italy did not reach a point of having to decide between which lives and which dies. Some of those reports, I think, were a bit sensationalized, just from the media aspect. But I believe as clinicians, we deal with these situations all the time. I think a very important aspect is a concept called co-production, where some decisions are not black or white. I think making sure that the patients and their families are also part of the decision making is important. I think this might sound a bit disconnected, but I believe the planning at the national level, at the regional level, should be disconnected from us as clinicians. We as clinicians, our daily objective every day that we go to work is to save lives and minimize harm. And I think as long as we focus on that and do that within kind of a risk strategy that is evidence-based, I believe we can always improve our capacity. One other thing that could help as well is for the system to function as a system. I think many healthcare systems, we've seen the fragmentation of the systems, because, for example, if you're an advanced hospital that is dealing with corona patients, then maybe you should also be helped by other hospitals to offload some of your load. So I think this is also an opportunity for us to work together, private and government, academic institutions, non-academic institutions. The more we try to work as a system, I think we could save as many lives as possible.
Yes, Director Generals have raised very good points, and then there are very good guidelines available regarding ethical issues in UK. And then BMA has come out with 9-page guidelines about ethical issues, and then how to triage, what should be the ethical framework, resource allocation, and medical utility. They have covered this topic very well, whether we should withdraw or withhold the treatment, direct or indirect discrimination in prioritization decisions, maintaining essential services, management of risk of healthcare professionals, impact on general practice. So they have very clearly defined everything, the importance of fair process, liabilities issues, whether there are any liabilities issues or not. They came out very serious advice about that. And then I would advise, please, audience, to go through those guidances, especially BMA, and then I quite like those things.
Thank you. We have many questions about extubating a patient with a COVID-19 positive. Dr. Gore, if you can comment on this event.
Yeah, so like we observe the PPE precaution during incubation, similar precautions should be observed while extubation of these patients, whether they turn out to be negative by the end of the treatment, because we have seen that many of them, they become COVID positive again. So we should take all precautions. And I was going through the question answers as well, President Saab, and one person asked that we should not reduce the protection for the anesthetists. No, please don't take me wrong. I'm not saying that anesthetists should not have PPE. What I'm saying is that probably anesthetists are protected better because they observe proper PPE precautions. So these are two different comments. A positive pressure theater means that air comes into the theater and then leaks out through vent, ducts, and scrub area, and then can, that is a hypothesis, that is well-known thing in indoor pollution. But then we can say in healthcare that can affect, because the respiratory diseases has been worked out very well, and then they have seen the cross-infection, how it happens. So yes, anesthetists should have proper PPE. Yes, please don't take me wrong.
Thank you so much. I think most of the question regarding CME hours. So we did apply for a CME hours pending approval. So all attendees, hopefully once we get that, we'll announcement. Professor Ahmed.
Yeah, thank you, everybody. I want to thank everybody for their valuable contribution, including Dr. Abdullah Hussawi, the Director General of Saudi Patient Center. Thank you, Dr. Abdullah, for your time and for your valuable presentation.
Thank you. Thank you very much. I think this is a very excellent webinar. I could see at some point that the participants exceeded 1,000. I think this again indicates how interested people are, and again for most of the participants, I want to also finish with the same beginning, what I begin with, which is, thank you very much for all the great, contributions that you're doing. I think, the solidarity that we've seen within countries and between countries in dealing with this, the great solidarity we're seeing in this webinar, where we have an expert like our colleague from the UK and different people from different sectors within Saudi, is just a testament to how resilient we are. I think there are many lessons learned that we can also come up with that will make us more prepared and more resilient for whatever problems that come up in the future.
Thank you. Great.
Thank you very much.
Dr. Gore from Leicester, UK, and again, we appreciate your valuable time and your valuable speech and lecturing.
Thank you very much for having me on the show. Thank you so much.
And I want to thank all the attendees and who had their time, and they bared with us and they listened to us up to the end. Thank you very much. And as Muhammad, my colleague Muhammad, he said that hopefully we're going to have a reply from the Saudi Council about the CME hours. Meanwhile, inshallah ta'ala, we'll hopefully, and I wish everybody Ramadan Mubarak and God acceptance bidnillah ta'ala, and hopefully to see you all in the future coming activities bidnillah ta'ala. Thank you very much, guys. Thank you.
كل عام وانتم بخير. شكرا، كل عام وانتم بخير إن شاء الله.
Thank you. مع السلامة. Thank you, Dr. Gore. Thank you.